Welcome back, warriors and supporters, for another great episode of CWF Presents CRPS/RSD is Real. This week we are joined by Dr. J. Kumar. His practice, Spine and Pain Specialist, is located in Charlotte, North Carolina. Dr. Kumar is very dedicated to his patients with the goal of always getting the most relief at the comfort level of the patient. And no matter what, even if he can't help you within his practice, he will never let you leave his office with nothing. He will always give you some kind of direction. So without any further ado, I welcome Dr. J. Kumar. Why don't we get started with how you learned about CRPS? What introduced you to the condition?
So I'm a board-certified interventional pain medicine specialist and also a board-certified anesthesiologist. I've worked in pretty much every practice setting that exists, meaning hospital, ORs, outpatient clinics, private practice, surgery centers. I've been treating and seeing patients with CRPS since I started my stuff, so probably around 2013-ish. CRPS has very specific diagnostic criteria, which I'm sure we'll go into in a little bit, but the treatment paradigm for it has been pretty limited for the most part. And one big thing is the earlier a patient's able to have these symptomatologies identified, the earlier a patient can start their treatment. And statistically, CRPS actually can self-resolve or at least begin to within 2 years. But obviously, the patients that I see don't always follow those statistics, and therefore I have a very algorithmic, stepwise treatment paradigm that I've been doing, and it's been very successful. Before I started my current private practice, I was faculty at Duke University Medical Center, and there is where, just like most interventional pain practices or areas, we have quite a few CRPS patients, and the mainstay is essentially just early identification, early treatment, and then obviously we can go into those details. But yeah, I'm very familiar with CRPS, the symptomatologies. It's a very difficult and tough syndrome to kind of deal with.
And it's different for every patient. It seems
Absolutely.
They have these symptoms, other ones don't, and then same with the treatment options. Some will respond well and others won't. So how do you adjust your treatments to accommodate that?
So there's two categories that come to see me. Category one is patients that are just starting to have this issue, meaning they went to their PCP, primary care doctor, and or they went to a podiatrist, and they would complain to these providers that, my foot seems like it turns red or it has these Budapest criteria type of symptoms. Those patients then are referred to me if they do end up seeing a provider that I've established a relationship with, meaning that podiatrist may be like, I think there's something else going on here, and send the patient to me for further workup, or same scenario with the primary care. And then so on and so forth, and we go down the paradigm. And then category two is patients that perhaps were managed and were early on diagnosed by whatever healthcare provider, meaning both specialists or non-specialists, and they have started their treatment, but either they've hit a plateau or they've seen one or two pain docs and they're not really getting the needle pushed a little bit, or in terms of improvement in their symptoms, and they're looking for a separate provider to kind of take over and continue their care. So those are essentially the two main categories of patients that come to see me. And based on those, which bucket, I guess you want to call it, a patient falls in, is kind of how I determine where in the treatment paradigm they start or they continue. So number one, I can go through the very basics.
Sure. If you want to go through the basics of what you would kind of lean towards on either side.
Yeah. So there's something called the Budapest criteria. The Budapest criteria is a diagnostic set of things that have to be identified, and they're both objective and subjective symptoms. And if a patient meets these Budapest criteria, they are considered to have the diagnosis of CRPS. There's two types of CRPS type 1 and type 2. Type 1 is when there's no identifiable nerve injury, and type 2 is when there is. And typically, I'll have a patient, let's say they had a foot surgery and there's not a particular type of nerve injury technically, but they had an incision. And so I, in my opinion, call it in that scenario type 2. But it doesn't differ the treatment paradigm, it's just a diagnostic name. So then once we see the patient, you begin the basics. So history and physical exam is the mainstay of CRPS diagnoses. You have to fulfill the Budapest criteria. It goes off of symptoms that are physical and subjective, meaning what the patient feels. And if they meet the criteria, the diagnosis is given. And then in general, if you look at any textbook, the mainstay of treatment across the board is physical therapy. But a patient can be the best patient on the planet and they'll go to the physical therapy. But if a patient's in pain, they're not mentally going. They'll go physically, but it's hard. Your brain is invented to protect your body. So you have to figure out alternative means to first bring the patient's pain down, motivate them, and then they build on the rest with physical therapy. But so that's essentially what the treatment paradigm is focused on, is figuring out an avenue where the patient can be doing these rigorous physical therapy regimens.
I
Yes.
like that too. The mental health component, very
Yeah.
important.
So, I mean, if you really look at the highlight level, big picture approach, like what exists in terms of treatments, you have medication based, meaning neuropathic agents. So we have Lyrica and gabapentin. Lyrica was made over 25 years ago, and we don't have, we have secondary and tertiary neuropathic medications, but they're not first line. First line is really just two of them. The problem with these two drugs is they're very finicky, meaning if they're not dosed properly or they're not titrated properly, then a patient will get a side effect. And then unfortunately, one of the two meds we have in the world are going to be ruined. So it has to be done very slowly and properly, which can be aggravating, but there's a reason for it. Outside of oral medications, and then you have adjuvant medications. You have Cymbalta, Pamelor, which is nortriptyline, things like that. But they're not primary treatments, they're secondary. And then I use a lot of topical medications. So sometimes I'll have a scenario where a patient doesn't tolerate gabapentin or doesn't tolerate Lyrica. What do you do then? I use a compound cream, which is where a pharmacy crushes 6 or 7 different oral meds and makes into a cream. I tell people it's not a magic potion, but it takes the edge off. And it's better than anything over the counter. I don't sell anything, it's just a compounded cream. It's a formula I got one of my previous institutions, and after 500 or 600 patients, it does something. So I copied that formula and provided it for my patients. I tell people again, it's not a magic potion, but it helps take the edge off, especially in the morning or night or both when neuropathy is the worst. So I tell people put a heating pad on the area of concern. After 20 minutes, take it off. And what that did was increase the skin temperature to help increase absorption. And then you put the cream on and then pass out. Another avenue that I call a symptomatic treatment avenue, meaning what do you do in those moments when it flares up? There's a device called Quell, which is essentially a wireless, glorified, interactive TENS unit. And it's wireless. And so the concept of a TENS unit is your brain can only focus on so many things at once. And your brain will focus on this mini vibration sensation. And in theory, the pain below it, not magic potion wise, but to an extent, will subside. It's a symptomatic treatment avenue. I'm a big believer in Quell. I mean, it's a wireless TENS unit, and the price of it, again, I don't sell anything. I just write the script. It's very reasonable in my opinion, and it's wireless, so you're more likely to be using it. And then, depending on does this allow the patient to better participate with physical therapy? If so, then we can pause in terms of other interventions and let the patient do what they need to. And if the answer is no, then I'll continue down, like I said, down the treatment paradigm. And then technically, the next item on the list would be a lumbar sympathetic block, which has been done since the early 1900s. And you don't do more than one, you do one. Have I seen it make a huge difference? on average, it's very effective, but the downside is it's very variable, meaning it differs from person to person on the length of how long it helps them. Once in a while, you will see that a patient actually responds for a year, and then getting this done once a year is not the worst thing in the world. Sometimes people will get 6 months out of it, and there you can kind of decide, is it terrible to get this twice done a year? And then after that, that's when it kind of gets different. Some people will have a 1 month variation, some people will have three, and it just, you have to weigh the pros and cons if this is worthwhile to continue or not, based on any other associated effects patient may get or not. After a lumbar sympathetic block is where neuromodulation is introduced. Neuromodulation is a way to kind of alter or change the perception of how much pain is going through the highway, aka the spinal cord, to the brain. So in general, I don't know how much people know about neuromodulation, but there's this word called neuromodulation, which is an umbrella term. And then below that, there's two lines. One line would go to spinal cord stem, and then the other line would go to peripheral nerve stem. One of the primary FDA indications for doing spinal cord stem was CRPS. And in addition to spinal cord stem, there's also dorsal root ganglion stem, or DRG stem. And data actually shows that DRG stem actually has better outcomes than dorsal column stem. But there's pros and cons for both. But all of these things are underneath the umbrella word of neuromodulation. And so the best high-level summary that I can give people is, so the modern day analogy for what neuromodulation is going to be a dog whistle. So back in 1952, spinal cord stem was invented. And back then, nothing to do with today, back then, the best analogy was a TENS unit. Not today, but back then. I want to emphasize that. So back then, what it was is basically you have your TENS unit. It creates this little mini vibration sense, and you turn the box off, the pain comes back. But if you have it on, in theory, the pain below it, let's call it knee pain, would subside because your brain would focus on this buzzing sensation. And then unfortunately, you turn the box off, buzzing goes away, pain comes back. So back then, again, not today, that's what spinal cord stem was kind of based on, along with this idea called gate theory. Essentially, whatever stimulus or input is the higher stimulus will overpower the highway and take over the sensation to the brain, and that's what you're going to feel the most. So now, through technology, every decade, things get better and better. And now, like I said, the analogy is a dog whistle, because we got the frequency of this electrical sensation impulse so high that your brain and spinal cord will feel a quote unquote buzzing, but you as an individual do not. So that's where the dog whistle comes into play, if that helps make sense.
Oh, it makes perfect sense.
So the beauty of at least pain stimulators is that you can try it before you get any permanent anything. You cannot say that about a pacemaker, a AICD, a sleep apnea stimulator, a bladder stimulator, none of it. You just have to get it. So the beauty is a patient can try this thing out. And I tell people that I want you to try this thing out like a sports car, meaning the whole purpose of a patient considering to do this would be to improve their quality of life. And so therefore, during that week, I need them to do those activities that define their happiness and therefore will improve their quality of life. And if a patient does well and truly gets their quality of life improved, and by definition, 50% pain relief, which I'll come back to that in a second, then they can qualify to get the permanent version. One big thing I tell my patients is we don't want to shoot for the bottom. The goal is to not have this be another domino on your list. And so at the end of the day, you hope for the best, plan for the worst. And if I were to have a patient shoot for 50, and then with that phrase, 2 to 3 years from now, let's say they go down to 25%, I can't really justify that. But if a patient gets 70, 80 plus percent, and then with that phrase goes down to 50 for whatever reason, I can still justify that. So my purpose is, we don't want to shoot for what the insurance requirement is. We want to see what this thing can do and then make a decision both primarily by the patient. And then if they want my opinions, I'm happy to help them through the process. I'm very, moral is not the right word, mentally supportive, maybe, for the patient through this process.
It is scary, and I think it's a process. Like you said, it's 2 times if they choose after the trial to keep it. And I think that that's scary to know that you're going to go through that twice, but the benefits are
Well,
can be
the bigger
incredible.
picture is there. Yeah, the bigger
Right.
picture is there. And as long as you have a doctor that you trust that will help you through that, that's what's invaluable, because we're not trying to make insurance happy. We're trying to make the patient happy here. And
Exactly.
it's my job to tell people, I mean, I'm not gonna sugarcoat. I have patients all the time that are kind of right on the seesaw, as I call it, like 50%. But I mean, I can tell you very honestly that there's several times where I will be like, I don't think this is right, because there's no way for me to fully understand, but I see it every day. When a patient's been suffering with chronic pain so long, it's not their fault. They're going to grab or try to grab for the next item that they think is going to help. But my job is to help protect them from that and tell them the truth, because is that if they don't, and let's say hypothetically they lie and say they get 70 or 80%, well, unfortunately it's going to become another domino on their list. So it is very important that you have somebody that you trust and can work with you through this and
I
will
really
tell
like,
you the truth when it's not worth
yeah.
it.
I really like that you brought that up because, somebody that has been dealing with this for 10 plus years and they're just have had not much relief or very minimal. And they want a day, a moment without pain so badly that
Absolutely.
people can
And
be taken advantage of. And to know that you are there and specifically prevent that in your practice is amazing. I think that people get talked into things sometimes, or they kind of just go wherever they're guided because they're willing to try anything, and everything is not always for everybody. So being able to look at each individual person and see what is best for that person and being honest and having that relationship with your patients, that transparency is exactly what warriors need.
yeah, it's important, because having this become another domino on the list is not, it's just not what is the intention. And also, the more that this is done the improper way, this will only hurt the therapy itself, because in general this therapy is life changing, but unfortunately there is no such thing as a blanket therapy for anybody. And not always will you have successes, and unfortunately there's going to be failures, but it's important to acknowledge those and know when you need to cut your ties, meaning, no, you did not do well, this is really going to be make things worse for you. I highly suggest we don't, but we did try it, and it was worth to try, and we gained information out of it at the very end. The beauty of spinal cord stim trials is that honestly it's identical to doing an epidural. The only difference is, instead of liquid medication going in, it's these flexible, blunt tipped spaghetti strings. Everything is done with image guided fluoroscopy. It's very accurate, very precise, down to the millimeter. And the big picture risk profile of this is very minimal in general. It's the same risk profile as doing an epidural, because that's essentially what this is, just without medication.
It can change somebody's life. My boyfriend has full body CRPS and he could not walk until he got the spinal cord stimulator. I mean, that's night and day right there.
And it's covered by insurance, as long as the steps are done properly. And to be honest, for something to be approved and covered and recognized by insurance, as hard as insurance already is to work with, that has to mean something. Otherwise, things wouldn't be approved and it would be cash based. But any good, real medical evidence based treatment is not cash based. It's insurance covered. And CRPS, both type 1 and type 2, are FDA indications for it. As long as the patient doesn't just go from page 1 to page 15. There's some,
Right.
it is frustrating, but you still have to go through the stepwise, because what if only pages 1 through 3 were done, but you actually were able to do your physical therapy and it worked enough that you can participate? Well, that's the goal. So it doesn't mean you have to do the whole book.
Right. Now, when you do physical therapy, do you do it at your office or do you send them out somewhere?
So the answer is based on each state. So in my practice, I have to refer them to a physical therapy location or a practice that has PTs in it, but it's most of the time option A. Um, I actually am very proud of the Rolodex of physical therapists that I've built over the last 2 years. Any person I refer to a patient to out of my practice, I have met each person, both physical therapists, physicians, everybody. And I do this because I would hope that if I was referred to somebody, that the person referring me would have met him and knows that he's legit. So that's very honestly, that's why. That's my motivating reason. So I basically pick it based on a patient's location. So I do have PTs that I know, like, all right, the physical therapist A is my go-to pelvic person. Physical therapist B is my go-to uh, cervical radiculopathy person. But when it comes to CRPS, the beginnings of it, if a patient hasn't even done anything, I will tell them to be picking a location based on what's closest to their house. So they're more likely to go. Then once they kind of graduate level one and they're in level two, that's where we can change. And I tell people, as long as you're happy with the physical therapist you're with, they all read the same book, but you don't necessarily mesh with each person. So just like when I said you have to feel comfortable with the doctor, the same scenario. You can't have somebody push you harder if you're in pain if you don't like that person. Very simple.
Right, right.
Yeah.
That's it. It's that, and I know that it's probably important too. Like you said, you want to meet them, you want to know they're legit, you want to know that they're going to take care of your patients. We also want to know that they know what this condition is. They've worked with it. As you know, going to see somebody that doesn't know what you have, like, doesn't always get you very far. And unfortunately, it seems like a lot of areas, like you said, a lot of things are location based, what's available to
Hmm.
you. I've noticed the farther down the East Coast, the more resources there are.
So far, the summary conclusion I've came to is it. Okay, I'll give you a good scenario. If you look at 5 years ago, both in Charlotte, North Carolina, and compare that to Raleigh. Raleigh is 3 hours east of Charlotte, but there were higher level, more advanced things being done from an interventional pain standpoint in Raleigh 5 years ago compared to here in Charlotte. But Charlotte is a very metropolitan, like bustling city. Actually, it's more metropolitan than Raleigh, in my opinion. But it's because Raleigh has the triangle, the research triangle, where they have Wake Forest, UNC Chapel Hill, Duke, East Carolina is in that area, all the major universities and medical schools. In Charlotte, we now have started construction on a brand new medical school, and it won't be done. I don't want to give a wrong date, somewhere 2025, 2026, something like that. But it is really important, actually, that I've noticed that those cities that have medical education, they seem to be more up to date, if there's a appropriate way to say that, compared to the outskirt cities that don't. My main motivating factor for moving back to Charlotte is number one, I'm from here, but number two, it's my hometown, so I wanted to spruce things up a little bit in an appropriate way without ruffling anyone's feathers. And it is very possible as long as you stick to the data and you do evidence-based treatments. And the other thing I'm big on is not doing something twice hoping to expect something different. And so what I
Definition
mean
of
by,
insanity.
yeah, I know. And what I mean by that is the cycle of pain injections that we did in the early 2000s, where you'd finish, you'd be doing okay for a while, then you go back to not being doing well, and then you just restart the cycle. And that just does not fly with me. The
Sometimes
goal
it comes
now,
back with a vengeance too.
yeah, and the goal now is to figure out if there is a way to treat the source, do that. And then number two, if there's a way to provide a long-term based treatment, then that is the actual goal instead of just kicking the can down the road. And most importantly, all these medications that we used to do, like all they would do is just provide fatigue, and then this patient would live in a fog for the decades to follow. So it's terrible. So I'm really happy that the space or field in general has been improving, and one of the biggest reasons I went into this is because of that. And the best way, fortunately or unfortunately, depending on who you ask, how do you treat the source of things without drugs? Well, it involves technology. And to me, that's a good thing. But what's more important is that a patient doesn't get scared with this technological treatment based items, but more so focus on starting at level one and then only doing what you need to achieve the goal of improving quality of life.
Right. And I think that that's the big picture of that itself, is that maintaining the improvement. A lot of the medications, in my own experience, I've seen is that, they mask the symptoms temporarily. Things don't stay better. And then it almost seems like they keep you stuck at it at times.
Mm-hmm.
So I'm assuming that sometimes when we talked about how you have the different categories of patients and when they come to you, what they've tried, maybe they've tried everything under the sun and they've probably been on a lot of these medications for quite some time that have been masking that pain somewhat. But once that tolerance, maybe is the word I'm looking for, gets built
Mm-hmm.
against those, now they're back and want something different because this isn't working anymore. But I've noticed also that they're afraid to stop taking the medication or to reduce it because it's their only lifeboat that they've had towards
Yeah,
pain relief.
I understand that, and I tell people this all the time is that yeah, even though this is a separate topic, but in general, pain meds can actually make neuropathy worse, and it's proven statistically. In a maybe parallel scenario, if a patient comes in and they're on like 6, 7, 8 different meds and they're still having pain that's 10 out of 10, I mean, I'm very honest with them. And what I've noticed is that a lot of pain docs may, for whatever reason, good and bad, they may come in, they notice the patient's on high doses of things, and they kind of say, sorry, I don't really do that. And that's the end of the encounter. What I try to do is come in, and obviously make us both on the same page that yes, you're on X, Y, and Z medications. And I kind of just talk to them like a person. I say, look, you can't be good at everything. And what I'm good at is trying to treat the source of it. There is no way to be good at this and this. And that is common sense, actually.
And
Meaning,
it's very real.
yeah. And I've noticed that every time I walk into the room for a new patient that is there to see if somebody can take over the regimen, whatever, they're just used to the quick in and out. And instead, I use that time frame, and I 100% of the time have learned that if a patient's on high dose pain meds, I straight up will ask them and I say, let me ask you a question. Are you still having pain despite all of these things that you're on? And they're 100% of the time, their answer is yes. And it's because they know it very well also that these meds are not helping them. But like you said, actually, it's their only lifeline and it's not their fault. They didn't get the prescription pad and write it themselves and go to CVS. Somebody started this scenario, and these people and these patients just need somebody to help them understand what the big picture of things is. And I, at the same time, what I do the most is I don't even tell them or comment about why they shouldn't be taking it. I instead say, if you really are looking for an avenue where we can try to treat the source, where you don't have to take any of these meds to begin with, I'm your physician. I can help you. But if you are set on continuing the route that you, as a patient, know works for you as a patient, then that's okay. And I give them a list of nearby resources that they can make appointments at. I say very clearly, I can't speak for them because that would be inappropriate. But here you go. Here's a list of the nearby areas that you can at least inquire. Because it's not my place to stop their endeavor, but it's my place to give them information, let them know why I can't do something. But if you want alternative ways to treat the source, it's a no-brainer. I'm happy to help.
I like that. No matter what they're going to leave your office with something.
Yes. Yes, I like that too, actually. Yeah, thank you. That's a very true
You're
statement.
welcome. No matter what, you're gonna do whatever you can, or send them or guide them where somebody can. And I really like that. I mean, I've experienced appointments where doctors just they don't believe you're in that much pain and you're here, or they don't believe your condition, or I've also had people tell me, they've been treated by a doctor that the name is on their paperwork, but they haven't met them yet. And
Hmm.
and like anybody in any project, if something is too big, it's hard to pick it apart to treat it. And
Yeah.
some patients receive a brush off, and to know that no matter what, you're gonna do everything that you can that to help them or guide them, that's very, very incredible, and honestly sometimes rare nowadays.
Yeah, and it's not always the doctor's fault. I have this
No.
luxury because it's my practice, but sometimes if it's a large institution, I mean, the doctor's just another part of the machine, and they have their own
Insurance doesn't make it easy for them either.
no, they don't at all. I actually had a scenario today, just to kind of piggyback off this, is like you mentioned, if everything is on fire, that a lot of times people get brushed off. It's not because the doctors want to, it's they don't know where to start. So I have a good scenario for today. There's a patient, female, not elderly, but I don't know, anywhere between 50. She was actually in her 70s, but anyway, it doesn't matter. So my point is, she came in and she said, my entire spine hurts. Okay, no problem. She had MRIs of every part of the spine, cervical, thoracic, and low back. She said she's been to 5 or 6 other docs, both surgeons and nuns, and nobody's been able to help. And so I said, all right, let's do something different. I want you to get your hand, or actually, before I did that, I said, I want you to look at the last 6 months, not yesterday or the day before or 2 weeks ago. And then I want you to get your hand and show me, like I literally make them get their right hand and literally point to the area of their body that hurts on a consistent basis that affects their daily activities and makes them change it. Because what I've noticed is a patient will harp on what their imaging report says. They say, I have a disc bulge on L5. Okay, but what are your symptoms? Well, my bulge is making like, I can't walk as much. Well, it's not your bulge. I want you to get your hand and show me what hurts. And so I've noticed when I do it this way for those particular set of patients, it's a different approach than anybody else they've done with. Not because I'm special. Again, it's communication. And it's important to, it's all based on what, piggybacking off what you said, is that you have to break it down. And if you have too many things on fire, it's no way to kind of hone in on one thing, because I always say, if I treat number 2 or 3 without treating number 1, you'll never be happy. So let's spend 5 minutes and figure out what is number 1. But they're like, holy crap, no one's ever asked me this.
Well, I think too that probably has like a automatic reaction for people. They're not, like you said, they're not focusing on the imaging and what the paper says, and they're not kind of overthinking it. It's point to where you're hurt. Their instant reaction is going to be what hurts the most.
Mm-hmm.
So I think that probably, helps them to be able to better communicate with you as well, to be able to really find that main source of the pain anyway. Which child screaming louder?
Mm-hmm. Yeah. The other most common thing I run into is a patient will have an MRI and it'll say they have a disc that's being in contact with the exiting L4, let's just say, for example. And then you go and you talk to this patient, and he or she said, I've had 4 epidurals and none of them worked, and I just need to resort back to what I was taking medication wise because I know that works. That happens to me daily basis. And I say, okay, well, and I ask them, okay, what are your symptoms? The same thing I just went through. And you come to find out that this patient never even had or has any sciatica or quote unquote like sensations down the leg. They only have just the back pain that stays in the back. And I say, well, you had 4 epidurals, but epidurals are only going to help you with shooting pain. So that's why you likely didn't respond. And if you dig deeper, you look at your MRI, and that's what happened. The patient had their MRI treated, they didn't have themselves treated. And I run into this every day. And so this is kind of my approach, just very basic. It's stepwise, and it's evidence based, data backed treatments, and only do what you need to get your goal, which is improving quality of life.
Right. Not everything else that's not going to help. That just improving quality of life. I always say even just a fraction of anything would be, grateful. The difference sometimes between somebody that is new with the condition is that they're in the mental space still of hope that for pain free, and then you
Mm-hmm.
have the veteran of this disease that thinks they're never going to have anything better. There's nothing that's going to help them. The mental space that somebody can be in this is very broad of the different stages of
I can
acceptance
imagine.
and hope
Yeah.
and willingness to try something.
Or just fear, because when you walk into these places, they might have these fancy machines and all these things, and I mean, an average person on the road has not been exposed to the insanity of what healthcare can be. But it's very important to just maintain. I'm talking about ourselves, healthcare providers. Like, we need to factor in that and not just go from 0 to 100 and scare somebody away. You just have to talk to the patient. That's it.
That relationship is so important because trust is a big factor here with your healthcare provider. Your life, your quality of life is in their hands, and to have that relationship and that open communication, it helps alleviate some of that fear at times, I think. But some things are just so foreign that they're just scary no matter what. But the
Yeah.
comfortable is not always healthy.
No, but what you just said is actually another reason. If anybody walks into my clinic, I mean, the entire thing is covered with models and spine images, and I have 3D models that are on touchscreen computer or screen in the room that patients can draw on, and I can email it to them. So I use a lot of visuals. My point is, so that when a patient comes, they don't just have their plan, but they know why that plan exists and what the goal actually is. It's almost like a live 3D animation that you see all the time on YouTube or maybe on an iPad, but in real life using a model. So, and I write everything down, meaning I'll tell them, like, this is the name of the stuff you would type in the box on Google. And I say this, or I give this to them, because everything's on the internet. You just got to know what to look for. And I tell people that are hesitant, I'm going to be the last person to quote unquote push you to do this, because that doesn't even make sense. Here's the info. I'm very confident it's going to help you. Look at it. And if you want to do it, I'm happy to talk to you about it.
How did you become connected to the foundation and decide to become a resource?
Let's see. What I do remember is somebody on your team reached out via email. I also, what I was going to say was, I don't have a huge strong presence on social media, but I have a presence. My handle, or whatever you want to call it, is at Pain Doctors, so it's pretty easy. Pain Doctors. And so I also know that somebody on your team reached out via Instagram, and then that message was relayed to me through my marketing team. And to be honest, why did I decide to get involved is, anytime I see an organization where I can help spread information, I say yes. There's no financial association with any of this. It's, at the end of the day, why would I have wanted to go into this field, is because it needs a little bit of sprucing up, and the more education we're able to spread. And while I have energy and time right now before I get old, I'd rather do that now. Otherwise, what was the point of dedicating your entire life and career to being a physician, especially in this field? But
Right.
right now is the best time, I definitely, in interventional pain, to go into this space, because things are just improving each day. We have more data, more studies,
And you did say that you started in this in 2013?
Yeah, so I went I started med school 2010, started residency 2014, and I did 2 fellowships. I'm a pediatric anesthesiologist as well, and then I did interventional pain. And technically, by definition, I can practice pediatric pain, but that's a separate conversation. And then before starting my own private practice in my hometown of Charlotte, which is called Spine and Pain Specialist of the Carolinas, I was faculty at Duke, and I was the only physician in my location in Raleigh. And I had 14 staff. I had a nurse practitioner, and within 6 months, uh, not because I'm special, but perhaps maybe because I practice or some of the characteristics that I have with how I talk to patients, but I was able to gain a really good reputation there, and that gave me the confidence to come back to my hometown and start my own practice.
I can imagine that just in that time, the leaps and bounds of the progression of treatment you've seen and different options and the improvement and just how things have changed over time just in that the last 10 years.
10 years. Oh, it's insane. It's insanity, but for the positive. And I can't imagine what the next 10 years will go. I know, for example, there's 2 medications in clinical trials that perhaps in theory could be Lyrica number 2 or Lyrica number 3. We don't know yet. It's still in clinical trials, but they will be released in 2025 and 2026. But that's just an example of what you just said, is that, yeah, each decade that goes by, things get better and better. Thank God.
Yeah, we're adapting. And in my opinion, from getting to know you a little bit here, your connection with the patients, it's because it's genuine, it's real, it's finding what's best for them, not just what's there or what is on the diagnostic and treatment protocol. You're willing and wanting to find what's best for them and their specific needs with the people that even have comorbidities, everything that
Yeah,
goes along with that as well, because that changes everything. We have a new map now.
it does. It's
And I
really
and I
important. You have to find somebody you trust and that you can rely on, and you may not find that in that physician right away, but don't give up, because there's a lot of physicians out there that are incredible, incredible.
that's the other key point I've noticed too. I think that you give patients what a lot of physicians forget. It's not that they intend to not do this, but you give the hope of prospect of something better.
Yes, I can't really think of a time where a patient will leave with nothing, like you said. Actually, I don't know if I realized that before you said that, but yeah, because there's always an avenue that hasn't been explored. It's just, is your person thinking out of the box? I can give you another quick scenario. Actually, happened today. Is a patient has intense pain, a different patient, but all throughout the spine. I know it's non-CRPS, but you can extrapolate out, meaning my point is that there is always a treatment. It's just a matter of if this is appropriate or not. But this patient has a fusion from T5 all the way down to S1. And so we've been talking, just as an example, spinal cord stim. Well, okay, this patient, we had about a 45-minute visit today. She was a new patient, and we went through all the things she's tried and failed, and I'm talking about her 4 surgeries. And there's a treatment, the avenue, that I'm very confident she would do well. The beauty is that she can try it, and it's called what we were talking about, spinal cord stim. However, she's fused all the way up till T5, and from a logistical standpoint, I don't have the avenue or access to do it properly. And so, how can this patient get this therapy? Well, think out of the box. So I coordinated with one of her surgeons that she's been following with, and I asked the surgeon, "Can you do a trial perm, or a tunneled trial?" Is what it's called. Basically, a patient that has a fusion with no access can get the trial, see if it improves her quality of life, done by the neurosurgeon, and if it does, It's done in a particular way where the patient can get the permanent version very easily, but only if she does well. But my point is, I don't focus on having the patient do their treatment in my practice just so I can continue to grow. That's not what we're doing. I thought out of the box. I'm very confident about the therapy. I then go out of my way to coordinate with her surgeon to see if that's something he'd be open to, and then I'm going to help kind of set this up so the patient cannot do it with me, but with her surgeon, who she's already established with. But nobody else that the patient has seen thought about this. So, just as an example.
You think about all avenues. I like that too. You're gonna make it happen.
As long as the patient wants me to. I'm very
Right.
respectful. So I say, with your permission, can I, for example?
Right. It's a whole new ball game when you know you have a doctor is in your corner, that they're gonna do whatever they can, reach out, and over time, you know, you've built that network that you have. So you have those connections to be able to, you know, give them something no matter what that they need and want before they leave. And I'm very impressed by that.
Thank you. Thank you. But yeah, if people ever have any questions, like I said, our Instagram or whatever social media stuff is at Pain Doctors on everything.
Is it doctor spelled out?
Yes,
Or
pain. Yeah,
okay.
Pain, and then Doctors with an S spelled out. Our webs, if you type my name in, you can find that on Google. And my practice name is Spine and Pain Specialists of the Carolinas. We take every insurance, even Medicaid. We don't do any cash-based items. It's all insurance-based and evidence-based medicine treatments. And yeah, it's
gonna ask about that. So I'm glad you brought that up about the insurance and working with patients, because I know that that's another area people have a hard time with. You know, your can't work, so you're on a budget, and then your insurance doesn't cover it. So it's very nice to know that how you work with all the insurances like that. So that's perfect.
yeah. No, we're always willing to help. Our website is www.spinepaincarolinas with an s.com.
And I will put all of that. I'm going to put your Instagram and your website and contact information in the episode description, so that with the hot links, so people can get right connected with you.
Perfect. Thank you.
And
yeah, if people ever have any questions, you know, we make an appointment. We see every patient, and we will do our best to get patients in ASAP. But yeah, we're always very willing to help, and you know, our goal is kind of everything we talked about, but the goal is different than what pain was 10 years ago. Things are now much improved, and if a patient kind of gave up from their attempts in the past, you know, it may not be a bad idea to at least ponder to revisit it with a particular individual that they feel confident in.
Right. And I agree 100%. I think that trust is where the willingness to try something again or revisit certain things would come in. So
yeah.
Well, I can't thank you enough. Do you have anything else you wanted to add in that we left out that you think is important?
If people have other questions, I'm happy to either we can have it a second podcast, or I'm happy to answer them via email. But it's a lot. You know, we went over a lot. I think if there's might be some questions or things that about particular treatments.
I can't thank you enough for taking the time out of your day to
fill us in and let us know and give us some hope.
Yeah, of course. Well, let me know if you have any other questions. I'll look out for your email. But it was great talking to you.
Thank you. You too.
And I can't thank you enough for sharing all that information with us and for letting us know that there are doctors out there that are looking out for their patients like you are. So if anybody out there would like to get in touch with Dr. Kumar, the doctor that will never let you leave his office with nothing, you can reach him via the contact info in the description of this episode. You can also find him under our resources tab on our website, crpswarriorsfoundation.org. If you would like to support the podcast and the foundation, please text CWF Podcast to 53555. Rockfest is right around the corner on the 27th, so if you haven't gotten your tickets yet, please do so. You can find the link for that on our events tab on our website and across our social media. Our next group is even closer. It is on the 18th. If you have not signed up, you still can do so. Registration is still open. This group, our resource Shannon Adams, is going to be a guest to talk about massage therapy and yoga nidra. As always, it has truly been a pleasure. If anybody has any questions, please feel free to email me or Dr. Kumar, and we will see you on the 1st.